Set, we're ready to go?
Yes, sir.
All right. So, hello everyone. This is a larger group than I usually present to, but today's topic is going to be special issues in long-term care. So what do we mean by long-term care? Nobody answers. This is a quiet group. All right, so long-term care, what we're going to discuss are issues that relate to individuals that may be in long-term care facilities. So these are individuals who may be in a nursing home or assisted living facility. So what we're going to do is to discuss, let's see. Okay, some issues that if you are going to be working in a long-term care facility that you should be aware of. So one very omnipresent process that you're going to face if you're in a long-term care facility are some of these items that I have listed in the agenda. So we're going to talk about surveys, collaborative practices, issues that relate to the residents. These are individuals who live in the nursing homes. So we don't call them patients. We call them residents. Falls, pressure ulcers, different kinds of infections, polypharmacy, medication adherence, and serious illness discussions, which also involve determining goals of care, and then issues at end of life, such as palliative care and hospice. So we got a full agenda. And we're going to start out by surveys. As I mentioned in the beginning, if you work in a long-term care facility, surveys are part of life. You are either in the middle of a survey, finishing a survey, or preparing for a survey. The regulatory surveys that are run by the New York State Department of Health as the agent for CMS, the Centers for Medicare and Medicaid Services. The regulatory surveys occur at least every 2 years, and these are not scheduled. They may occur earlier than 2 years. They may sometimes be delayed beyond 2 years. And so those are the annual surveys or biannual surveys. There are also complaint surveys. So if your patient or the family member has an issue, they are able to call the Department of Health and voice their complaint. And then depending on the severity of the complaint, the health department may send someone into the building to do a further investigation. There are also issues like falls with serious injury, and those types of incidents may trigger a survey, and it's expected that the facility report these things. Now, sometimes you may have a resident in the facility who falls, injures themselves, ends up in an emergency room or gets hospitalized. And then the emergency room or the hospital may report this injury to the health department, and that may trigger a further investigation. So the idea behind these surveys is to maintain quality of care within the facility. It's to ensure that it is a safe environment, to ensure that the residents are being afforded the highest quality of care, and that we maximize their independence and we maximize their functionality. So these are the regulatory surveys. How does this involve you? Well, it either involves you because you are providing care for a particular individual patient, or you just happen to be in the building and a surveyor comes over to you and questions you about a particular issue. So that's how it's going to involve you. They look at medications, they look at numbers of medications. For those of you who are doing geri-psychiatry, they look at the residents who are on antipsychotics or psychotropic medications. And these may be sedative hypnotics, they may be antipsychotics, they may even be medications that you are giving for depression, or medications that you are giving for someone who has Alzheimer's disease or dementia. And those are considered psychotropic medications. So you may be questioned as to why this individual is on that medication. When did you last assess that resident to see if an adjustment in the medication was indicated? So these are the sorts of things that you may face. What is the importance of these surveys? The importance of these surveys is that if an issue that is of immediate danger to this individual that they're looking at, or other individuals, other residents in the facility may be affected by this, they may, it may affect the function of that nursing home. If there is something called immediate jeopardy, meaning that they feel that there is an immediate threat to the safety of patients in that facility, they may request an immediate intervention by the nursing home. And what do they look for? So I already mentioned, they look at medications. They look to see whether there are individuals who are bedbound, because the idea is that we want our residents in the facility to reach their maximum function. And that means that they should be getting up out of bed each day. We look at the quality of the time that they're spending out of bed. So if this individual requires therapy, whether that therapy is physical therapy, or if it is occupational therapy or speech therapy, it's up to the facility to provide that type of care. We also have what's called patient-centered care. And what that means is that the facility and its staff is there to function to give that patient the type of care that the patient requires. So if that patient wants to sleep late in bed, then it's up to the facility to make accommodations, unless there's a medical reason for that not to happen. So if the patient requests breakfast at 11 o'clock in the morning, then it's up to the facility to make accommodations. If the patient does not like the food that's served, then it may be up to the facility to make alternate food arrangements. If that particular resident wants to have a bath or a shower every day, then it's up to the facility to make accommodations for that. Now, the New York State Department of Health is not the only agency that surveys facilities. Now, many of you may have been in a hospital setting where the Joint Commission has come in. So not a lot of nursing homes undergo Joint Commission accreditation the way they do in the hospitals. In the hospitals, Joint Commission takes over the role of the New York State Department of Health, and they do the survey in the hospital for the Department of Health. Now, there are other groups that will do surveys. So there is a group called CARF, which is the Commission on the Accreditation of Rehab Facilities. And this organization comes into the facility to assess whether the quality of that particular facility with regard to rehabilitation services fits up to their standards. And their standards may be different from the Department of Health because the Department of Health is looking at patient safety and CARF is looking at how well the rehab department functions and how well the facility supports that department. All right, so collaborative practices. So what do we mean by collaborative practices? So by collaborative practices, we mean that there are in a nursing home a variety of different arrangements. Some nursing homes have staff, physician staff, nurse practitioners, physician assistants who are paid by the facility. There are other facilities that contract with physicians to provide services to the residents in that facility. And the physician practices may have arrangements with nurse practitioners and physician assistants who work for that particular physician practice. Now, there are other groups, and other groups include what are called institutional special needs programs or ISNP programs. And these are programs that contract with an insurance entity, and they provide clinical care, and they work, and the clinical care is provided by nurse practitioners and or physician assistants who work with a primary care provider to provide the optimal care for those particular patients or residents in the facility. So who the advanced practice clinician works for depends on the particular setting. Now, what is telehealth and telemedicine? Those are terms you should make yourself familiar with. So telehealth is really providing healthcare off-site, utilizing either an iPad or an iPhone or other devices where the physician or the nurse practitioner or the PA are not in the building. They are elsewhere, and they may do their regulatory visits and other interventions on a periodic basis using these devices. Ideally, what you would like to have is a setting where the patient and the provider can see each other. So what you find sometimes is if the particular provider is contacted by a nursing staff member in a facility and the issue may be a rash, the nurse may be able to take a picture of that rash and forward it to the provider so that they can make some sort of an assessment. The intervention may be a history. Tough to do a physical exam from a distance, but there are some apps that are available for phones that allow you to listen to the person's heart or listen to the person's chest or listen to their abdomen and perform that kind of an assessment from off-site. And telemedicine is really the provision of care from this off-site process. Now, where does the resident have to have their care managed? So up until this past year, the care provided by telemedicine or telehealth was only permitted in rural settings. And with the COVID pandemic, the federal government opened up these interventions so that it's not just not relegated to rural settings. And so what you find is that providers are providing this kind of service even in city facilities. So, what we find in some nursing homes, it used to be that, they don't necessarily have a provider in the building 24/7, the way that you have it in a hospital. So they may have a situation where there's a decompensation of the clinical condition of a patient, of a resident, and the nurse contacts a provider off-site. And at one point, when they were doing telemedicine, they would have a cart, and the cart had a camera on it. The cart had a device that would allow the nurse to move a stethoscope and do the examination and transmit the findings to the physician or the nurse practitioner or PA. So these devices have now been supplanted by an iPad or an iPhone. So it's a little easier to handle these kinds of services, these kinds of assessments from a distance. And so there are some contracted entities that provide this night call service. And so the provider is not called, but these services are called to do an assessment. And these assessments may depend on what type of telemedicine provider is staffing that service. If it's ER physicians, if it's hospitalist physicians, there's a high risk that that person, that particular resident patient, may get sent out to the emergency room. Ideally, what we want to do is to provide the service that the patient needs at the right time, at the right place, and the right kind of service. So ideally, we would like to provide the service in the nursing home. So you don't have to bundle a patient up and send them off to an ER where they'll sit for a long time on a hard stretcher. And, these types of services may be able to be provided in the nursing home. So what is probably one of the major reasons why patients or residents in the nursing home end up getting sent out to an emergency room? So one of the big reasons is falls. So why are falls an important issue in the nursing home? Well, you're dealing with frail, elderly people. Some of them may have osteoporosis, so they are more fragile. If this individual falls, there's a high likelihood that they will break something. And if they break something, what does that mean? That means a decision needs to be made as to whether an orthopedic operative repair is going to take place, or whether someone will decide that that is not indicated in this particular individual, and then the patient may get sent back to the facility still with the fracture to have union of that fracture taking place by non-operative means. People don't fall without a good reason. So one of the things that you want to do if you have an individual in the nursing home who falls is you need to do an assessment. The assessment needs for you to look at historical information, what type of medication the patient is on. You may also want to know what the underlying issues are for that patient. You want to know if that resident is a mobile individual or whether they are bedbound. You want to know if there are recurrent falls and what were the findings indicating a cause for that particular fall. So these are the sorts of things that you want to do in terms of an assessment. And I mentioned in the fourth bullet down, a falls assessment tool. So some facilities may actually have a written document that covers a variety of different areas. You know, is this person on medications that may result in orthostatic blood pressure changes? Is this individual on medications that may cause confusion? And that type of confusion in the middle of the night may contribute to a fall. If this person has had prior falls, have interventions been put into place to prevent future falls? So, is the bed able to be lowered in the lowest possible position? So, there are some beds in nursing homes that can be lowered to less than 16 inches off the ground. That means slightly over a foot. There may be cushions put beside the bed so that if the resident in that facility falls out of bed, they will fall on a cushioned surface, not on a hard cement floor. And they will be less likely to injure themselves even though they have fallen. Has the person had any orthostatic blood pressure changes? Has this individual been receiving medications for diabetes? And maybe the person is falling because they're hypoglycemic. Is the person on a diuretic? Does this person fall out of bed because they need to void? And that's why they're attempting to get out of bed. So you need a bit of an assessment. And that assessment is a review of the history, but also at the time that this patient is found on the floor, to do vital signs, to see if the blood sugar is of a reasonable level or whether the person is hypoglycemic, to see whether that particular individual has any type of orthopedic issue prior to the fall. Was this person falling out of bed? Was this person walking to the bathroom and they became incontinent and they slipped on the urine? Were they wearing shoes that have a tread? Or were they walking in socks on a slippery surface? So you want to do these kinds of assessments in anyone who has fallen. And then you want to get a better idea of whether this person has any abnormal findings on physical exam. Did they hit their head? Do they have mental status changes? Do they have some impairment of movement of an extremity, indicating that maybe there's a fracture? So these are the sorts of assessments that you want to do. If the examination doesn't yield anything, then this person may be able to be managed in the nursing home with further assessments being done at a future time. So which patient should be sent to the emergency room? So you have somebody who is on an anticoagulant. So that person falls out of bed and hits their head, and now they have mental status changes. So that person should be sent out. You have an individual who is a mobile patient found on the floor and has the inability to move an extremity, or when you examine that extremity, there is movement in a location where there is not normally a joint. So that indicates that maybe there is a fracture. So those types of individuals really should be sent out to the emergency room for further assessment. So you have somebody who falls, and they fall because they're walking around and they have a vision impairment. So should that person be restrained? So the answer is you really avoid either physical or chemical restraints in individuals in a nursing home unless for medical necessity there is an indication for the restraint. And you have to try non-pharmacologic interventions, and you really have to have very good documentation as to why you are using a restraint. And that restraint should be used, if at all, for the least duration. And restraints not only include a vest restraint or restraining their extremities, but even...
Okay, I'm tired. I'm not gonna lie.
Hello, hi. But even the use of side rails. So side rails are also considered to be a restraint. So you really want to try to avoid the use of restraints for falls, and you want to try to, if need be, have someone sit in the room with the patient so that they can intervene if that patient attempts to get out of bed, and that's a reason for the fall. All right, so pressure ulcers, another big issue. So pressure ulcers in nursing home patients, what causes them? Pressure. So how do you avoid pressure ulcers? You try to avoid pressure ulcers by ensuring that those particular issues that contribute to the formation of pressure ulcers are minimized. So you want to get that patient up and moving around so that they're not sitting in one position. You want to be certain whether this is in fact a pressure ulcer and that it is not something related to venous stasis, that it's not something related to poor circulation, such as an arterial insufficiency ulcer, that this is not related to diabetes, that this is not a neuropathic diabetic ulcer. So you really want to try to do that kind of an assessment. And the management makes a difference. All right. So pressure ulcers, your goal is to relieve pressure. If it's an arterial insufficiency ulcer, you want to see what the circulation is to that part of the body. And if possible, to try and improve the circulation. If the person has a diabetic ulcer, what you want to try to do is to ensure that they have good control of their blood sugar. And then there are other kinds of modalities that you can put into place. So what is the grading system for pressure ulcers? So the grading system for pressure ulcers is on a scale of 1 to 4. It does not apply to the other kinds of ulcers. So venous stasis ulcers, arterial ulcers, and diabetic ulcers are not graded on the same scale. And so that scale ranges from a grade 1, which is slight discoloration. It may be a stage 2, which is a blister. And then you have the more serious types of ulcers, which are stage 3 and stage 4. Stage 3 going into the subcutaneous tissue or adipose tissue, and stage 4, which is down to the bone. And how do we assess for infection in these ulcers? Well, you look for erythema. You look for pus. And what you don't do is you don't do a swab culture. In other words, taking a Q-tip, rubbing it across the ulcer, and then seeing what grows. Because frequently what you'll end up with is just whatever that person's skin is colonized with. And that doesn't help. So if you have an area where you think there is infection, that may require a tissue biopsy so you see what's actually affecting the tissue. And that's how you may make a determination of what antibiotics you're going to use. Who requires antibiotics? The people who have an infected pressure ulcer, but they only get the antibiotics until there is healing. You try to make sure that there is debridement of any dead tissue, because the dead tissue does not get antibiotics permeating it, and it's not going to help treating the infection. You try to open up any loculations of pus and abscess, because again, the antibiotics won't get into the abscess. And the other modalities are going to be looking at what the person's nutrition and hydration are, and to see if you can mobilize them and try and remove the pressure. And there are a variety of pressure relieving devices. Do you use what is called a donut? A donut is a circular inflated device which is put around the pressure ulcer, but you try to avoid that because that type of device just impairs circulation to the center of that donut, to the tissues that there, and results in a worsening of the pressure ulcer. All right, so what is another issue that's important in the nursing home? As you can see on this slide, infections, sepsis, and this year, COVID-19. So sepsis in nursing home residents is a big deal. There were 19,000, almost 20,000 emergency room visits for severe sepsis, and that has been an increase when you compare similar age population of non-nursing home individuals. There's twice the ICU admission rate for septic nursing home residents, and there's an average 2-day longer length of stay for septic nursing home residents who end up in the hospital. There is a higher mortality rate, and the types of infections that most commonly results in a referral to the hospital are respiratory and GU types of infections. So in other words, pneumonia and urinary tract infections, with skin and soft tissue infections occurring less commonly as a diagnosis is associated with severe sepsis. So what happens with sepsis? There is a progression, starts out with an untreated infection that leads to sepsis, that may lead, if it's untreated, to severe sepsis, and then in its extreme, leading to septic shock. So SIRS, systemic inflammatory response, that diagnosis is made by two or more of the following: a fever, either high or hypothermia, tachycardia, tachypnea, or an elevated white blood cell count, or in certain individuals, leukopenia. Now, in those people with a leukopenia, you're looking for the number of bands or immature cells. So sepsis is SIRS due to infection. Severe sepsis is sepsis complicated by organ dysfunction, meaning there may be cardiovascular, CNS, GI dysfunction, liver dysfunction, and then there's septic shock, which is sepsis-induced hypotension that persists despite adequate fluid resuscitation. And even not only that, but pressor drugs as well. So, there are assessments. The idea is you want to try and find something that is quick and easy in terms of doing your assessment. And so somebody came up with a quick scale, and that quick scale is somebody who's tachypneic with a respiratory rate greater than 22, somebody who's got altered mental status, or hypotension with a systolic blood pressure less than 100. The challenges are many people have altered mentation, delirium, or dementia. And so that becomes a problem if you are not familiar with the patient to try and make that determination of what is altered mentation as opposed to what is the person's usual level of confusion. Delirium may be more difficult to discern, again, from baseline dementia. Infections may present atypically, and the dilemma is the rapid initiation of presumptive antibiotics may run counter to a facility's antibiotic stewardship program. In other words, there are facilities that correctly don't want to have indiscriminate use of antibiotics, and so they try to limit the use of antibiotics. But if you have someone who is showing signs of infection, you may want to initiate antibiotic therapy while you're doing the assessment, and then come back in 24 or 48 and 72 hours, and then reconcile what your labs show with what antibiotics you're using. Is this a viral syndrome that may not benefit from antibiotics, or does this person have something more serious that can benefit from intervention with antibiotics and other things? All right, so the goal in nursing home is to identify and treat early sepsis, thereby avoiding the need for hospital transfers. The SIRS criteria that I mentioned is sensitive but not specific. It's specific, if you have someone who has a source of infection. There is something called the 100-100-100. So a heart rate of 100, a blood pressure of 100, and a temperature greater than 100. It's easy to remember, but its sensitivity and specificity need some further testing. And you may need to combine these with your clinical evaluation. And if sepsis is probable, early interventions in fluids are important, but early antibiotics are really what is most important early on. All right, so COVID-19 in the elderly. So how does age affect mortality and morbidity, and what organ systems are affected? So in the elderly, they are at higher risk for developing other infections, and that includes viral COVID. And so a variety of different organ systems can be affected, everything from CNS and mental status, cardiac. There are people who develop pericarditis associated with COVID. There are individuals very commonly who become short of breath. And one of the things you may have difficulty differentiating is this COVID, or is this someone who just has decompensated COPD, or someone who has decompensated congestive heart failure? The kidneys can be involved. There are skin manifestations that can also be evidence of a COVID infection. So what comorbid conditions affect survival? The fact that they may have underlying cardiac or pulmonary disease, the fact that they may have obesity as an issue. So these are all issues that can affect survival. How is infection determined? So you use PCR or rapid antigen testing. And the problem with rapid antigen testing is that there may be false negatives. And PCR right now is the gold standard. So if the person has either a positive PCR or a positive rapid test, that patient has COVID. What's the role of antibody testing? Well, antibody testing is useful if you want to know whether that person previously had a COVID infection. It doesn't tell you whether that person currently has a COVID infection. That's determined by PCR or the rapid antigen testing. So what treatments are effective, and which ones are most effective? So, if you've been following what's happened with COVID, people have been put on things such as vitamin D or drugs like Plaquenil, or recently something which is an antiparasitic drug called ivermectin. And people, physicians and other providers put their COVID patients on these medications without really adequate research supporting the indications for that. Does zinc work? Does vitamin C work in treating COVID? Not really clear, but if you're in facilities, you may find providers prescribing that. There are things that right now seem to work. So if you have someone who has tested PCR positive and they fit the criteria for it, there is something called monoclonal antibodies. And the monoclonal antibodies have an emergency use authorization to be used early on in the case of COVID. So person tests positive, you don't wait till they become severely short of breath and need to go to the hospital. The idea is you test them and then you try to give them the monoclonal antibodies, even if they're asymptomatic and they fit the criteria for being at high risk. You try to give it to them within 7 to 10 days. Once they are severely short of breath or they've dropped their oxygen saturation, that person may need to go to the hospital. And there they may give that individual dexamethasone, or they may give that person some other drugs like one called remdesivir. Decadron in appropriate individuals may affect mortality and morbidity. Remdesivir has not been shown to have an impact on that. And its effectiveness is to shorten the hospital length of stay. So we're going to quickly go over this right now. Serious illness conversations. All right, so what do we mean by a serious illness conversation? So for each of the residents that you're taking care of, you should have a discussion with the patient. If the patient or the resident is capable, is cognitively intact enough to carry on a conversation indicating what they're looking for in terms of care. Are they looking for longevity? Are they looking for comfort to be made free of pain and other adverse symptoms? You know, do you have the conversation with that resident? Or if the resident is not capable of understanding, do you have that conversation with the next of kin or the proxy? You know, we have them because you don't want to wait till that patient, that resident crashes and becomes either hemodynamically unstable or in some other way unstable in the nursing home. And you have to talk with the next of kin in terms of what further management may be required. Now we have them, as I mentioned, with individuals, with residents who are able to have decision-making capacity at the level that is necessary, or with the proxy or the next of kin. And you have them frequently so that you're able to make certain that you and the resident and the staff of the nursing home are really on the same page in terms of the type of care that that resident wants. And these things need to be documented in the medical record. Does this person have a healthcare proxy? So that's very important. You should, even if the person is cognitively intact, find out from that resident if they become mentally incapable of making decisions, medical decisions, who do they want to have decision-making capacity? And that may be a relative, it may be a neighbor or a friend, but that's the time at the beginning when they're able to make those decisions, to make the decisions. And there is a very low decision-making capacity required to decide who is the proxy. It's different from asking a patient or resident whether they want cardiac surgery. It's different asking them who they want to make the decisions if the patient, the resident, is not able to make those decisions. And what is a guardian? So a guardian is a court-appointed individual. So they have to go to court. Sometimes that happens either when they have a lot of conflicting family members, or the person is what we call unbefriended. They have nobody. They come to your building and there is no family, there are no friends. So the court appoints an individual. Now, frequently, the guardian may be for financial decision-making. The person happens to be wealthy and you want to make certain that they're not taken advantage of. So that's a guardian for property. But frequently what we would like is we would like guardian for healthcare decision-making. And those are the individuals who you work with to try and make certain they understand what the resident's clinical condition is and what the goals of their care are. So what's a MOLST? A MOLST in New York State is medical orders for life-sustaining treatment. It can be completed by the resident. It can involve a physician, or in New York State now, a nurse practitioner or a physician's assistant to complete the form. The patient may give you verbal indication. There may be family members who are in another part of the world, and they may be able to give you some direction. But those directions done off-site should involve a witness. So there are some phones that allow a three-way conversation. So there should be someone who witnesses this discussion. And the discussion is not only about do not resuscitate or do not intubate orders, but it also involves, do I want to go to the hospital? Do I want IV antibiotics? Do I want, other interventions, a feeding tube? Or do I want a trial of these interventions? And how long should that trial take place? It needs to be reviewed periodically. So there needs to be a review process that takes place every 2 to 3 months to ensure that there are no changes. There are end-of-life discussions, and end-of-life, if you haven't looked at the goals of care, you're already missing the boat. So what you want to do is you want to have those end-of-life discussions early. And again, as I mentioned in the last slide, not just a DNR, DNI, what's a do not hospitalize order and how binding is it? Many of these orders are binding at the time that the decision is made, but they can be rescinded at any time. What's comfort care and how is it different from palliative care? So palliative care is palliation. It may be of pain or shortness of breath. It doesn't necessarily mean that that person is at end of life. Comfort care is somebody who has a terminal illness and they may be in a facility that does not provide hospice care. Polypharmacy, a big issue in the nursing home, big issue with the elderly because they have so many coexisting conditions. So you should look at what are unnecessary medications. If you have somebody who is getting dietary supplements, they don't need to be on multivitamins or B complex or thiamine because the dietary supplements have it. Some big offenders are oral diabetic medications, antihypertensives, and statin drugs in individuals who are at the end of life. So terminally ill people are not going to benefit from statins. It takes 2.5 years to begin to see the benefit of a statin drug. Antihypertensives, you need to evaluate whether someone already has a good blood pressure. Their blood pressure is 90/60. Do they gain any added benefit from being on antihypertensives, or can you adjust it? And oral diabetic medications, hemoglobin A1C of 5 in an elderly individual just exposes them, along with a lot of antihypertensive therapy, exposes them to the danger of falls. And we're going to move ahead now. And I think we've reached sort of the end. I think it's 4 o'clock.
Yes, Dr. Kenner, thank you so much for such a wonderful presentation. I believe we can dedicate a couple of minutes for questions if we have any. Team, do we
Well-
have any questions?
Yeah, this is Shirley Gerard calling. Thank you for raising lots of really important issues. Where do a lot of our, much of our grant, our GWEP grant is really focused on primary care. And I think we might want to have you back to talk about the issue of transitions and handoffs. Because I've worked on both sides of the fence, if you will, and I've worked in long-term care. And there's some really important issues that we could talk about for our primary care providers in terms of handoffs from acute care to residential care for older adults. And then also to talk about sort of compare and contrast trying to maintain older adults in their homes and some of the innovative models that are out there that we can talk about. But I think maybe we should schedule, since we're already on to our next event, we should schedule something to have that dialogue if you're interested.
Oh, absolutely. Absolutely. That would be fine. Major issues in transition from whether it's from hospital to nursing home to assisted living to home. Major issues.
Right. Thank you.
Thank you.
Okay.